Dr. Jasmine Saadatmand, one of the psychiatry residents at Yale, and one of the Women's Mental Health Conference Planning Committee members. I'm passionate about the field of reproductive psychiatry and women's mental health and hope to practice in the field someday. I have been inspired by the work that our panelists do to advocate for women's health. For these and countless other reasons, I'm honored to be moderating our panel today. For our event today, we envisioned an interdisciplinary panel focusing on approaches to women's mental health from the perspective of experts from different specialties and areas of training and practice, with emphasis on how things have evolved during the pandemic. As the field changes along with the world in which we practice, a broad expertise and engagement with other providers becomes essential. All four of our panelists have been inspirational in their respective fields. The opportunity to hear them on a panel together will undoubtedly reflect the issues of the moment, as well as future directions in the field of women's mental health. I would now like to introduce each of our panelists. Dr. Nita Landry. Dr. Nita is a board-certified OBGYN who is known for co-hosting the Emmy-Award Winning talk show, The Doctors, for 5 seasons. She has also served as a medical expert for numerous shows, such as The Today Show, Good Morning America, Dr. Phil, and Iyanla Fix My Life. Additionally, she has been the keynote speaker and moderator at influential events such as the United Nations Foundation's Mom and Social Good, the nation's largest women's expo, and the Essence Festival, just to name a few. She loves educating and uplifting youth and young adults through A Healthier, Happier Me, which is a nonprofit organization that she founded. Dr. Nita is also an author. She has a women's health book that will be released in 2022. Welcome, Dr. Nita. Dr. Sayida Peprah. Dr. Sayida Peprah is both a licensed clinical psychologist and birth doula. She specializes in multicultural psychology, trauma, suicide prevention, and maternal mental health. An advocate for human rights in childbirth, Dr. Sayida is a member of the Black Women Birthing Justice Collective and a collaborator with the Black Mamas Matter Alliance, promoting research, education, and community-based services to positively transform the birthing experiences of Black families. Dr. Sayida supports community doula efforts as a co-director, doula mentor, and trainer for the Frontline Doulas and the Sankofa Birth Workers Collective in Southern California. Dr. Sayida is the founder and executive director of the nonprofit organization Diversity Uplifts Incorporated, focusing on fostering diversity and supporting diverse communities and the providers who serve them. Welcome, Dr. Peprah. Dr. Alexandra Sacks. Dr. Alexandra Sacks, MD, is a women's health psychiatrist and author affiliated with the women's program at the Columbia University Medical Center and the Columbia University Psychoanalytic Center for Training and Research. A leading expert in matrescence, she is known for popularizing the concept in her TED Talk and in her New York Times articles, where she is a regular contributor. Dr. Sacks educates the public about women's mental health issues as the host of Motherhood Sessions, a podcast with Gimlet Media and Spotify, and is co-author of the book, What No One Tells You, A Guide to Your Emotions from Pregnancy to Motherhood. Welcome, Dr. Sacks. And Dr. Carly Schneider. Dr. Carly Snyder, MD, is a board-certified reproductive and perinatal psychiatrist with a unique approach that combines traditional psychiatry with integrative medicine-based treatments. Among many other honors and awards, Dr. Snyder was recently named a 2021 New York Super Doctors Rising Star for the 3rd consecutive year. She's a regular contributor and an oft-cited expert for many popular parenting websites and news outlets. Her radio show, MD for Moms, streams live weekly and is available as a podcast. Original writing is on her website, Medium, and HuffPost blog, among others. Welcome, Dr. Snyder. Thank you to all of you for being here with us today and being a part of our panel. Before diving into our questions, I wanted to give each panelist the opportunity to tell us a bit about what inspired them to do the work that they do. Let us know about any current work that they're doing that they wanted the audience to know about, or anything else about themselves that they wanted to share before we begin. So maybe we can start with Dr. Nita.
Hi, everyone. Thanks for having me. Well, as you mentioned, I'm an OBGYN. And for me, one of the big reasons I wanted to become an OBGYN is because I watched women give and give and give when I was growing up. And in a lot of instances, because they were giving so much to everyone else, they left very little time for themselves, and their health suffered a lot. So I wanted to find a way to remind women that they deserve the love and care that they so generously give to everyone else. So amongst a lot of other reasons, like me just being a weird kid that wanted to read science encyclopedias and like become a doctor, all of those things just came together and made me want to practice medicine, specifically be an OBGYN. And one thing that I did that was a little different was after graduating, as opposed to taking a traditional job, I decided to be a traveling doctor. So do locum tenens, which allowed me to travel across the country practicing medicine. And that's been an amazing experience. So I've just been having a lot of fun practicing medicine and being a media expert and just kind of creating the path that I want for my life.
Thank you so much for sharing that. Dr. Peprah?
Yes, again, thank you for having me. I was in grad school studying for psychology and, very much, wanting to go into mental health. And then I decided during grad school that I wanted to have a child, and I felt like it was really time for me to start my family. And so interestingly, then I moved into this world of maternal health and my own experiences. And while I was studying, child development and, all the things that are, in preparation to be supporting families, I was going through my own unique experience being pregnant and then having children. And actually seeing that even in the work that we were doing through the school was not really focusing at all on maternal mental health. There wasn't really any context for very brief chapters on like the stages of, motherhood. And I really recognized even then how little the field had. And so it became something really relevant to me that when I was in the field, I would really focus on doing something around connecting maternal health and mental health at the time, when it wasn't really an active conversation like it is now. But then I also became a doula while I was in graduate school. And so simultaneously to being a psychologist over the years, I've been a doula. And so I've been able to support families, particularly women and children, in homeless shelters and community-based services and, doing, very active acute mental health support in psychiatric hospitals and in prisons, but then also at the same time, very often going into hospitals and home births, supporting, mothers and families having their children. And so I have a very sort of unique place where I sit in this work, in a very personal place, but also in the professional world as well.
Thank you so much for sharing. Dr. Sacks?
Yeah, hi, good afternoon, everyone. And I just want to start by saying it's so exciting to be on this panel with the other panelists. I'm really in awe of your backgrounds, and it's very fun to be in conversation with you. I'm lucky to know Carly from prior, but it's really great to hear your stories and meet you both. And also the women who organized this conference, pretty phenomenal that you're able to do this as students. So thank you for bringing us all together. So yeah, my background is I'm a psychiatrist, but I was really unsure about where I wanted to contribute. I was always interested in women's issues. And after graduating, I actually ended up working for Eve Ensler's organization. So I was excited to see that she's been involved in this conference and violence against women advocacy. And I had an interest in writing as well. So as I was working clinically, I wanted to figure out how to be able to contribute in terms of advocacy around women's issues and also communicating with the public, because I felt like I wanted to use my ability to write to communicate directly with women. And I found that a lot of opportunities in academic medicine were around writing for other clinicians and for the field, which is obviously so important, but kind of want to encourage everybody to think about going directly on your own path, which I think the other speakers are also saying, to communicate directly to the public. And often that involves sort of having to step outside of the box of different traditional paths in medicine. But I've been really enjoying doing that. I think it's creative. I think it's helpful for quality of life as well, to think about how you really want to live, even if that's not a traditional medical path. So I've been fortunate enough to sort of balance initially working in hospitals and then working in my own private practice and writing. So balancing that, and then eventually was able to participate in creating a podcast. So this year, as I'm sure we'll talk about during the pandemic, my work has been primarily clinically focused because the need has just been so tremendous for women and mothers, especially at home. But I'm excited to talk about all these different ways that we all contribute and thinking outside the box and thinking for ourselves as women in terms of creating the lives and careers we want, even if they're not traditional paths set up.
Thank you so much. And lastly, Dr. Schneider.
Hi, can anybody hear Dr. Snyder?
I can't, and I was wondering if
No.
anybody else could. Okay, I was like,
Yeah.
it's maybe my mic.
Sorry, we still can't hear you, Dr. Snyder. Maybe we'll come back to Dr. Snyder for her intro.
Yes, that sounds good. So the tech team will be on it. So we will get back to Dr. Snyder. Apologize for that for your intro. But just wanted to open up and you alluded to some of the other work that you do and was hoping to kind of start there. So all four of you are doing work to advocate, to educate, spreading what you know, engaging in dialogue through your writing, your podcast, speaking engagements, and more. How do you see that as being important for the kind of change that can happen for patients, as well as more broadly culturally, especially in the realm of women's mental health? So I'll open that up to whoever wants to begin.
Well, I'll start. I mean, one of the things that I has been particularly inspirational and important for me in my work, and I'm curious about the other panelists, has been sort of stepping outside of the medical model and a disease-centered model to talk to women. I think there are so many systemic issues that contribute to mental health and kind of human emotional experiences that our patients bring us, and also the phenomenon of motherhood and giving birth. It's not a disease. So I think that really what's been inspiring for me and kind of required to create in medicine is conversations for women about their experiences with their bodies, minds, families, stress, that are outside of showing up with a disease and illness needed to treat, and preventative and wellness oriented conversations are normalizing transitions and stressors. And I think that is really kind of unique for our community of women's health in terms of systemic issues that the community needs support with and language to help capture their experiences, but stepping outside of really traditional models of diagnosis and treatment. And it sounds like the other panelists' work engages in that as well.
Yeah, no, I was thinking similarly with working with the community. And so, you were talking about engaging with the field, but the conversations in the community, especially around maternal mental health, is like, postpartum depression and like, this idea of maybe she's going to kill her baby or she's going to, and a very, real reality for some people, but also a bit of a barrier for people to feel like they want to address, feelings of anxiety when they're pregnant or feelings of overwhelmed with what happened in the birth experience and wanting to talk about moments where they felt like they experienced some trauma or they're having some trauma come up during the course of, the perinatal period. And so really normalizing that, particularly in the Black community, I found that, there's a lot of stigma around it, but mostly this thought that like postpartum depression is a white thing. Like this whole like perinatal mood disorder is something that happens, other communities have time to fall apart when they have a baby. And I don't have time for that. I'm going to keep moving. And I think, Dr. Landry, kind of mentioned that with her own family, also like watching people choose or having to keep going and being so active and not being able to take care of in various ways. I've seen that in my own family. And so shifting narratives within the community around what are we saying maternal mental health? Well, we're just talking about sometimes not feeling like you have what you need within your own, support system to do it. So then finding help, within the local community or stretching outside of the community, talking to people about difficult emotions that are coming up, and it not meaning that, are they going to say I'm crazy? Are they going to diagnose me? Like really letting people know that, having emotional support is not about that you have to go see a doctor because you're sick. And I think a lot of that in the doula world, where I'm really trying to encourage doulas to understand mental health, to understand ways to sort of support people emotionally, because doctors are not the only people that interact with pregnant people. And, the general support teams can also be really educated so that they can be a bit of a buffer and a mitigator. And a lot of things just need a listening ear, but they can go awry without people that understand what it looks like when a person is going from mild anxiety to like an acute something that is going to need a higher level, and having those in between people know how to navigate the system as well.
For me, I think it's just important to use platforms to make people feel comfortable having the conversation. Because you think about it, why is mental health, why is it a taboo topic anyway? It's a taboo topic because a long time ago, some people who are no longer alive sat down and said, you know what, diabetes, that's not anything to be embarrassed about. High blood pressure, that's okay. Go to the doctor. No, it's fine. If you have those things, you can treat those things. Don't be embarrassed. But for whatever reason, they decided that mental health was going to be taboo. So if you're depressed, or if you're anxious, or if you're suffering with anything in that space, then they made it seem as though you were less than, and that you had something to be embarrassed about. So if you don't like the conversation that people are having, what do? You change the conversation, which is why it's important to be on platforms, just having conversations between everyday people, like saying, hey, yeah, these things do exist. And you know what? It's not taboo. It should have never been labeled taboo. And we keep talking about it and talking about it and talking about it until people realize that it's nothing to be ashamed of. And people understand that they're doing themselves an injustice if they don't get the proper treatment, because if they're not treated appropriately, then they're not going to be living the lives that they deserve to live. So I think it's important to just have the conversation until this whole topic of mental health is truly normalized.
Thank you all. And Dr. Schneider, did you want to answer the question or go back to the intro? Oh goodness, this audio. Okay, we'll keep.
Yeah.
So sorry. So continuing, all of you kind of brought up this importance of having a broader conversation, and kind of dovetailing off of that, women's mental health topics have been highlighted more in the media, more and more in our day-to-day language, especially topics such as infertility, pregnancy loss, perinatal mood and anxiety disorders. Can you please share with us what your views are on this change, and where would you like to see the discussion progress from here?
I mean, big question, kind of to piggyback on our last question. I think that in terms of why is it so important to have conversations for women outside of these disease models? Well, I mean, I think it's important to also ground this conversation in that our medical training, our medical research is oriented historically to male bodies. Right. And so I think that even to look to our patients and outside of disease models to hear more about their experiences, infertility is something that women need to speak up about if they're struggling and they come to their doctors. Right. And it's only an area of research that we can really build on by hearing more about the need. And so on, birth trauma, so many of the issues that you listed. And I think the cultural overlap is so important. Right. So let's take infertility for an example. Women, we know right now historically are delaying pregnancy, delaying childbirth, in part because we worked so hard to join the workforce and have equal opportunity to men. But sort of this presents a new experience around disease, right? In terms of what we've done as a culture to try to get healthier and have equal opportunity in the workforce. It creates challenges for women vitamins, because then after doing their, like all of us, medical training or other opportunities, how do you then have your body say, okay, I'm ready to now build a family, or for, like you said, Dr. Peprah, where you sort of stopped in your training to have a child. So these are, in terms of the workforce, and being around the experience of a male model, a male body's experience, in terms of maternity and paternity leave, all of these issues, these are cultural systemic issues, not even to mention things like systemic racism, that make things much more complicated for women. And then, are they diseases in terms of at the individual level, or are these larger cultural systemic pathologies? Because we don't live in a society that's really geared towards women and their needs and families' needs. So I'm curious about, and I think that also really directs to why, like Dr. Landry said, it's so important to speak directly to people on platforms to learn more from our culture about where the need is.
Oh, absolutely. Thank you, Dr. Sacks. And just wanted to take a moment to test Dr. Snyder's audio again. Dr. Snyder.
How about now?
Yes. Oh, yes.
Oh,
Good.
good.
Thank you to our IT team, and thank you everyone, especially Dr. Snyder, for your patience. So if you would like to go back to the intro question, anything you'd like us to know, and then.
Sure. I think very quickly. So I am a reproductive psychiatrist in New York City, and I was really drawn to this field in part as a mother. In my training, I looked back and I remember thinking that I had the flu after my son was born, that like never got better, it seemed. And in truth, I didn't have the flu. I was depressed and I didn't know anything about it. And then in the setting of then being in my training, I realized the need, and having a second child and realizing the difference between the experience when I was feeling like the flu and when I was enjoying the process of being a new mother was so profound. And I was excited at the opportunity to help other women. And consistently throughout for the last many years, I have been in awe of women's strength. And I'm a very big believer that everyone deserves to enjoy motherhood, even though it's not always easy. And I really, I found in terms of, using social media and writing and all of that, that there are so many women who don't have the opportunity to see someone like myself, like any of us. And by virtue of using these platforms, being able to kind of get the word out, for example, as others were saying about stigma and what's treatable, for example, and it really broadens the discussion, which has been great.
Thank you so much. And just wanted to see if Dr. Peprah or Dr. Nita wanted to comment on kind of the change in how, as a culture, we've been viewing these topics and where you would like the discussion or where you envision the discussion progressing.
Well, I am very excited that we're having these conversations more and more. And when as I traveled across the United States when I was practicing medicine, it's very interesting how different populations approach mental health. And, a lot of it is kind of what you see in your environment and what's normalized for you. So I would like to be in a place where we can really hear from women, like really hear from women. The government spends like all of this money saying we're going to implement all of these programs. And then in some instances, everyone in a position to make decisions, they're male, or the people making decisions aren't really representing women as a whole when we think about different ethnicities and things like that. So where would I like to see the conversation go? I would like to see the conversation go to a place where women are really able to voice their concerns and tell a group of people what they need, and have that group of people really implement changes that will move the needle and improve the lives and well-being of women in this country.
I love that point. When you said that, it made me think about one of the organizations that I work with, Black Women in Birthing Justice out of Oakland, California. One of the projects that we did was interviewing women who had given birth and other birthing people in California, asking them their experiences and having them tell their story about what it was like to be pregnant. And a lot of information came out about maternal mental health issues and just mental health and emotional wellness and stress. And so what I've done when I do trainings in hospitals on, implicit bias and working, with cultural groups, I bring in the stories and I'm like, so instead of us sitting here talking about like this intellectualized conversation about perinatal mood disorders, let's listen to how people describe what it felt like to experience depression or experience a traumatic response to something that was happening from their own words. And it's very moving, and it does shift the conversation from like the academic and like sort of this like looking at the other to like a real human experience that makes sense. And it's like, oh, wow, this was a really complicated situation. I mean, I remember one of the stories, the woman, I think she was on her 8th child, and she had given birth initially when she was a teenager. And now in this iteration, her telling the story, she's like, I want to say in her 40s. But she was talking about how much trauma she experienced going through pregnancy and childbirth as a teen mom in the beginning, because people didn't listen to her and people, took for granted that she was, understood what was happening because this was her 3rd baby. And so you must understand, and just the lack of support that she had in the environment. And by the time she's in her, final birth, she's really traumatized at the experience because she had had so many negative experiences with various providers, social workers, people who were trying to be helpful, but who really weren't centering her needs. And I think it's because people don't hear the stories from the people, and we're just like having conversations in academia among ourselves. And like you said, often, with people who aren't even in the population necessarily birthing and not necessarily connected as much to the community. I think the other part too, and kind of to touch back what was said earlier, when I look at like international studies of, perinatal mood disorders, I see a huge difference in our disparity in the States versus other places that we would think have more stressors, right? People maybe live in more experiences of poverty and there's lack of social systems. But the way that we don't support women and mothers in this country sets us up to have very difficult experiences in childbirth. I mean, even, noting, that I gave birth when I was in grad school, but I actually didn't stop grad school. I continued on. And my colleagues that were males who had children in grad school, well, their wives were doing it and they maybe took a week off and they just went through and it was like nothing, seamless. There was no need for consideration for them. Not that they didn't need it either. But when I was, pregnant and I was in my period of time, there was an extreme lack of consideration. It was like, well, you decided to inconvenience yourself to have a baby during grad school. So no, we're not going to make any accommodations. And I wasn't needing accommodations for them to do my work for me. I wasn't needing accommodations that would be beyond it. I needed to be able to space my time the way I wanted. Sometimes when people get a hernia, they take a semester off, or they decide to go traveling, they take a semester off. And so I really wasn't necessarily accommodated to do that. I had to find my own way within the system to have my family and finish grad school. And I was able to do it without ever having a break. But I did extend it and I did something unique that hadn't been done. And I pushed it because I was like, I definitely have the right to have children and to be in grad school. Like and it was literally just because of that inherent bias that, being a woman and then / having a children, because for a lot of women, they're taking care of family, they're like caregiver roles. So even if you don't have children, you're like often pressured by something else in your familial environment. There is an accommodation for that. So when we do have these stages of life, we want, to have a workforce of women in America, but then not have, accommodations. My brother and his fiance live in Germany, and they just had a baby, and she gets 3 years off and she has income guaranteed for the year, and she has nurses that come to her house, and she was assigned a doula for childbirth and a separate doula for postpartum, all free, all part of her insurance, period. Not because she has money, not because she's special, not because she lives in certain areas, not because she got the best insurance, because she's a human being and she's giving birth for the nation to bring more people into the world. And it's just like the way we set up women and families in this country puts all the pressure on the mother. And so then if she's depressed, if she's feeling anxious, if she feels overwhelmed, if she can't figure out how to support herself when no other systems are supporting, we shouldn't even look to her to pathologize that. Like, we should say this system is not set up properly. And then what do we have to do about the system? Because we have parallel systems that are doing really well with perinatal mood disorders. And it's a very simple, obvious thing that you see, and they're supporting birthing people and families.
Can I just also piggyback on that idea that in our culture, right, 2 days if you're lucky, maybe 3 if you have a C-section, and you're kicked out of the hospital and that's it. And you know, there's sort of a good luck, and you know, and that unto itself is a very scary situation. I mean, it's just, for lack of a better word, I mean, it's very unnerving. But then pile in COVID-19, and now you're not even able to go home to perhaps your mother, perhaps your, you know, a friend, someone to support you in the process. And I've seen so many women are having a much more fraught time in this period because there aren't the supports. There aren't the supports from our medical community, and there isn't support available as much from family because of the understandable risk. And they're so isolated, and isolation, you know, coupled with sleep deprivation and everything else. And it's a perfect storm.
And thank you for highlighting these kind of critical issues, and just kind of shifting a little bit to I think we're heading in that direction, but shifting to a more kind of clinical focus. You know, many members of our audience are either practicing or training to practice in a clinical setting. So just wanted to hear from all of you, you know, what are the important points of intervention for collaboration with other specialists in the care of patients in your specialty? Any advice that you have for clinical students and clinicians early in their career on adapting to more collaborative and interdisciplinary models of care? And of course, as you brought up, in the setting of a pandemic, some of the availability and some of the rules change. So maybe we can start with Dr. Nita.
I think collaboration is definitely very important. And as practitioners, I would just, you know, encourage everyone who's in this area to make sure that you are actually communicating with the next person, the next provider. You know, I think a lot of times patients can get lost in the shuffle when you refer them to a doctor and that doctor's doing this one thing and you're doing something else. And both of those are essential for the patient's overall health, but you're not communicating. And if you really look at what that other provider is doing, and if they pay attention to what you're doing, then the patient will do so much better. But I think overall, just acknowledging or understanding when it is important to bring in someone else from another specialty. Like, for example, for the field of OBGYN, for me, a big one is sexual dysfunction. Like, people come in and they have a low libido or something like that, and they just automatically think that it's something dealing with their genitalia, and they get a cream or something and it's going to make it all better. Well, we're very complex human beings as women, right? And we know that a lot of things come into play when it comes to sexual satisfaction. And what I find is, you know, a lot of women will have relationship drama, and that's the reason that they're having sexual dysfunction. So me just saying, oh, let me give you this specific treatment isn't going to be beneficial for them, because that may not be what needs to be fixed, or maybe it's a combination of things. I need to do something, but they also need to see a therapist, or they need to go to counseling as far as their relationship. So for me, my takeaway would be, you know, you just want to really listen to your patients and hear what they're saying, because I want to say this, it's very sad to me, and it's surprising that whenever I tell a woman who has been to a number of doctors, well, from what you're telling me, this is what I think, but what I think isn't, you know, necessarily falling in line with what you are experiencing. For instance, you shouldn't be having that level of pain based on what you're telling me, but I'm not going to tell you how to feel. You're a woman, you know your body. And women say, thank you. and it's a sincere thank you, as if they've been dismissed and disregarded so many times that they just assume that nobody's really going to listen to them. But to specifically answer your question, I think a big thing is just realizing when it is time to bring in someone else, as far as bringing in another specialty or another discipline.
I just want to highlight what she said too. Like, if you hear, she's really using language that is like in cultural humility, like having humility when you're talking to your patients and to your clients about their concerns, like assuming that they know more, assuming that they have information to tell you that you don't know. So it's very typical, especially when you're first coming out of school. Like, I have this book, I know all this information, I remember this from residency and this happened. And if this happens, I'm gonna do this. And it's like easy to sort of get yourself ready thinking I'm gonna have the answer to everything. But the first thing you wanna do is like, come with all the information and like, maybe have it on a sheet of paper, like considerations, rather than like, I'm going to make a determination about this until I feel like me and the patient have an understanding that they feel like I heard them fully and they're communicating to me that, yeah, you really got that. No, that's it. And you'll know it the first time you meet, like she said, you'll meet people and you communicate something and they feel so relieved because they've been in this rat race where people are telling them something, even if it's that they don't understand enough about their situation. And a lot of times, getting them to understand more information, like doing what we call psychoeducation in mental health, or doing health information for the client, it makes it so they can also communicate better to you what's happening. And it's just a much better relationship when you're in a space of humility about not knowing everything and that this is their body. I think the other thing too, in this, like, what could students and providers out there do to connect with other professionals? If you're in a field, think of all the things that would touch your patients. And as things come up and you realize, oh, I didn't know this, it's not like, oh, that's one referral. Get to know that provider. I mean, I have midwives in the community who know me as a maternal mental health person. And so they call me and we consult together on cases. And I consult with them, with OBs and nurses and NICU people when I have individuals who are experiencing specialized needs. And so you should have like a variety of providers in your pocket, not just to refer, but as your friends, as your colleagues, go to dinner with people, go to their conferences. I mean, especially University of Michigan has a nice OBGYN psychiatry, psychology unit connected. And so they do trainings together, they do courses together. And so then that naturally means that they're gonna know each other. And so you're gonna call people and that not just for fields, but also for the diversity of the providers. So people who are in the LGBT community, individuals who are from different ethnic and religious cultures, like, make it your business to have enough of a reference so that you could be really available for all of your clients, however they present.
Yes.
Go ahead.
Such well put points. And I think it's really so much about patient-centered education. And also, especially for all of you who are just finishing your training, to know how siloed medical education is. And that will really continue after practice if you don't kind of try to look around and work holistically. To know that it's actually really bad for patient care to go in, do your job, get your chart done and get out. And I know that it's so hard, especially as we're thinking about, you guys as human beings, and that you all have places to be at the end of the day. And there's just so much paperwork, again, these medical models that we're all kind of trained in, but you will miss things that relate to your patient's diagnosis and treatment and good care if you don't leave some time to just stop and listen and say, what do you need to tell me? Outside of anything on your checklist, outside of anything that there's a space for in the chart. So to really remember that your patient is the expert first and foremost, and to stop and listen and then figure out what they need and how to then do your job after starting with them. Yeah.
I was just going to add, having a network that you can refer to, people who you trust as a provider, is so beneficial for your patients, because now they really feel supported, and they feel like, and picking up the phone and calling that person saying, hey, I just referred a patient to you. This is her situation. And then when the patient goes and sees that other provider, they, oh, I spoke to Dr. Snyder and she said X, Y, and Z, and they feel nurtured and they feel taken care of, which is what people are meant to feel. And especially in the setting of having any, being pregnant, postpartum, any of the above, many women feel as if they're not being taken care of, as if their role is to take care of others and they're left waffling around. So giving them that feeling of being protected can really be beneficial. And, I would say also, though, the one area in what we do where I think people really are misunderstood and is PMS, or really more PMDD. The number of women who come to see me who have been discounted and told that their symptoms are, not real, when by all accounts they are absolutely real and they're very treatable. And then once you actually hear them legitimize what they're saying, they're so appreciative, let alone treat them. It's you really change someone's world and they feel so much better about just themselves. And it's just important to remember that each person's story is not just in the moment, but it's coming to you with these experiences, which really can be could have had negative repercussions. And part of our job is to undo that and to let people feel heard and taken care of.
And if I can just add one more quick thing, I think this goes back to what everybody is saying, but it's so important for people who just finished training. You gotta listen. You have to listen. And I know you're busy, and I know you have to chart, and I know the powers that be are telling you to see 4 annual exams in 30 minutes, and you're thinking about all of these other things that you have to do, but patients, they don't always know what to tell you. And like she said, everything isn't going to be on that checklist. It's a good checklist. I'm not saying you shouldn't have some type of idea. Like, you can't just go in there talking about goats and milk and when you should be talking about something else. Like, you should have a plan, but everything isn't going to be on that checklist. And you let patients talk, they'll tell you. It may be at the end, they'll talk for 30 minutes about a mild rash that they saw on their thumb, but it comes and goes. And when you have your hand on the door 30 minutes later, and they'll be like, and I fainted and I have palpitations and my legs go numb. Does that matter, doc? But you have to get to that point. So sometimes what you need to know doesn't come at the beginning. Sometimes what you need to know isn't on your checklist, but you have to give them the chance to tell you, because that's why you went into this profession. You went into this profession to help people, not really to do all the checklists that the powers that be make us do, but that's another conference.
No, I appreciate all of those points. Very well put, everyone. If it's all right, we wanted to open up the discussion to some audience questions. One question actually comes from a medical student that's almost, I think, the flip side of what all of you are saying about listening, and it's on the topic of disclosure. So one audience member, Layla Hariri, asks, in terms of normalizing mental health, the way hypertension and diabetes have been, and getting rid of the idea that it's taboo, do any of you ever discuss personal emotional challenges with patients? As a medical student, I have been able to connect with patients and build great rapport by sharing with them about my anxiety issues. So I open that up to anyone.
I can start by saying I wrote a fair amount about anxiety that I experienced following the loss of a twin pregnancy, and how much I was very, very nervous about my children's safety following that. Like, I was hypervigilant. The what ifs overwhelmed me for a while. And so I do use that. So there are some roles for disclosure, as long as it's really ultimately about the patient, that we're not, the disclosure is not for the, purpose of saying, oh, and I did X, right? That's irrelevant. The relevance is for them to feel solidarity and to know that they're not alone in having had whatever experience, and to, but it's not, I think it's always important to remember this is not your friend. You're not out for coffee and kind of talking about going back and forth as much as you are. When you disclose in a specific way, it's to help them appreciate what's going on for them, not to focus on yourself.
I would add to that, if it's something that you have not processed yourself with a therapist or with a professional, it's probably something you should wait to self-disclose when it's a good moment. Because typically what you will see is sometimes, patients, and I would say even myself, having dealt with some clinicians where what is happening to me seems like something that happened to them, particularly in childbirth. It gets a little hairy because people feel really connected to what happened to them. And then I didn't do this. And then I ended up in a C-section. So you got to make sure you do this. And I've watched, professionals work with patients in very personally triggered ways. Right. And so it's not super helpful. And they think they're really being helpful. Like they are trying to be helpful, but they're actually creating a lot of pressure and a lot of unnecessary fear because of their own unprocessed wounds. And so I would say really make sure that you do your own processing first. And if you have, clinical supervisors or, people who you can talk to, run it by them. Like if it's something that you think, I know that I'm going into this field and I have this personal experience of blah, blah, blah. How could I share that when necessary in a way that's affirmative for the client? Like let, someone who has experience kind of help tease that out, like on a practical level. But definitely it has to be because it's relevant to them, right? So it's not like, because it's going to be the thing you're going to start off with every time somebody has a similar event, but maybe you see that they're having a hard time talking about it, or they non-verbally gesture to you that they're uncomfortable with telling you. And then it's like, listen, I know that this happens. I've had some experiences like this. I've worked with hundreds of clients that have had experiences like this. These are some things that people sometimes feel. Anything like that sound familiar? Like there's ways to sort of neutralize it and not make it so specific to your story, but still let them know that you empathize.
Yeah, absolutely. I think so well put. And to piggyback on some of the other comments as well, I think that, starting out in your training, and I remember feeling this way, you're so much closer to the experience of being a patient than being a clinician. And it's one of the most powerful tools you have is to be so close to that experience and relate. But just trust that over time, you will kind of grow. I don't wear a white coat anymore, but I remember the feeling that I had to like grow into my white coat. It felt like this costume I was putting on. And, in psychiatry, we use this term about transference, which is how patients see us and all of the powerful emotions from their past that they bring in. And someone said on the panel before, I don't remember who it was, but how important it is for especially women to have the experience of feeling cared for in the clinical situation, because we in our culture are primarily caretakers, to just know how special it is for that person to come in and to be under your care and to feel like it's their story in the spotlight. And to just trust that, you don't have to tell your story in order for them to feel that way. You can create what we call holding environment to really give them the feeling of being at ease and that they're in your hands and that their story is real and that it matters and that you're really sharing and feeling their emotions. It's really, I think, often more about empathy than it is about adding in your own narrative that will lead them to feel the most understood and most cared for. And also, just like Dr. Peprah said, to avoid that kind of relating, because all of our stories are unique and uniquely charged by our own experiences. And so two people, their miscarriage stories may represent very, very different narratives. So be mindful of that.
Thank you all. And I see that we're getting close to the end of the time. I thank all of you for your time and for sharing with us. If we wanted to just kind of in wrapping up, thinking about anything that you wanted to touch upon that we didn't get to yet, something you wanted to share, particularly with the students, the trainees, the new attendings, the new clinicians in the audience who are inspired by you all as I am and want to do similar work, what would that be? And maybe we can start with Dr. Peprah.
Yeah, I think, remembering that, just general life stressors can be a huge precursor for a lot of mental health concerns. And so as much as possible, no matter what your role is, checking in about life stressors and understanding what are the other factors outside of just the medical scenario that they're coming in for, that might be, connected to what's happening. And that might create more barriers, even for them to engage in treatment, for them to engage in consistency with, interventions that you might have recommended. And also separately, really connecting as much as possible to community-based resources for groups, right? And so, people may be coming to you in one place, but it may not be the place where they receive their most supports or where it's most likely for them to connect to services. And so making it your business as much as possible, or making it a secretary's business or someone who's a navigator in your system, to know what is more accessible for your patients where they are in their own proximity, and that represents their cultural group as much as possible. Because we do see barriers with, a lot of communities engaging with medical care because they feel like it's disconnected culturally. And so just being mindful to collaborate with organizations that are local so that you can have those connections.
Thank you. Dr. Snyder?
Sure. So I think that's all so valid. It's so important. And I think in addition, as a new doctor, I think it's important to remember that every person's story is important to them in the moment, right? So you go from patient to patient, and sometimes you're with someone very, very, very sick who, and then you transition to someone who conceptually, for us, they're not as sick, but they're sitting there with you and they need your help as much as the other person, and really trying to separate each experience so that every single person who sees you feels that you are present for them in that moment, and that what they are experiencing is valid and worthy of being heard and being cared for. And at the same time, also taking care of yourself and being mindful that it's very hard, to be present for everyone, and you need to be present for yourself, and you need to find time for yourself, for your own interests, for your hobby, for your family. It can be, there's a drive sometimes to get in as many patients as you can, and to be as, especially when you're new in practice, because, at that point it's hard. There's a lot of time sitting and playing Sudoku or something, waiting between patients, but you need to be okay, and you need to be at your best in order to be present and be the most helpful. So, breathing and taking time and enjoying life outside of your practice.
Thank you. Dr. Sacks?
Yeah, I think, I agree with so much of what's been said. And I sort of think of the model of being an artist and being trained classically to have to sort of sketch the human form exactly, and then being able to branch out into abstract painting that has nothing to do with a person. So my medical training has been like that. I found it really hard and really confining to have to fit in the box in training and have to take all of the tests and do things exactly the way that my attending said. And it is so important to learn the classical traditional ways. It is hard and grueling, but it is so important. I really do believe that model is an okay place to start, but just to know from all of us further along that you can branch out and become more creative and more non-traditional in the way that you like to work. You give up so much to serve others, and the financial burden, the hours in your youth that you're going to be sitting in the library, just to know that you should build the careers that also serve you. You're going to continue to serve the community, but to keep checking in on how the work feels for you, when you need breaks, like Carly said, when you want to kind of branch out, like so many of us, and Dr. Landry, and so in awe of the work that you've done, to really leave the medical community, speak directly with the general population, to do things your way, and to not be afraid of that. And especially as women, as that relates to your personal lives too. So to just know that the road is long, but you'll be able to kind of find more of the balance a little bit later. It's very hard to find, I think, in the early years of your training.
Thank you for that. And Dr. Nita?
Yeah, I would just like to piggyback off of what you said, because I think that's so important. I would just say, just dig deep and follow your dreams. It's great if you're in the health space, and that's amazing and that's fantastic. And I think some people, this is what they want to do. They want to be in that practice for 50 years and they want to see however many generations, and that's amazing. That's great. But if at any point you feel as though you're not happy just doing one thing, it's not that you'll necessarily walk away from this space. It may just be that you need something else. And maybe it looks crazy to everybody else. Like, I get it, because my mom was like, now say what? So you're not going to work today because you're going to go on Hollywood Boulevard and ask people questions on the street. Is somebody paying you to do that? I'm like, no, mama, but in my heart, that's what I want to do. So sometimes even the people who love you the most and have the best intentions won't necessarily understand whatever dream that you have, but that dream was given to you. It wasn't given to them. Not saying you have to be disrespectful, not saying that you should ignore everybody else's advice, but I'm just saying don't minimize or disregard your spirit of intuition. And life is a journey. I'm just assuming that I might not be coming back. You know, I don't know, reincarnation, a thing, not a thing. I don't know. So I'm just gonna say, this is it. This is all I get. So make sure that you are living your dream, because it's very easy to fall into this rut and end up living the dream of somebody else. Or at 40 or 50, you're still living your 20 or 30-year-old dream, which was fine for then, but you've just changed as a person. So just listen to your spirit of intuition, go find your happiness. You're in an amazing place. Congratulations on getting into training, finishing training, doing whatever you are doing right now, but just find your happy and go get it.
Thank you so much. I am just vehemently nodding yes and just saying yes to everything all of you have been saying. Thank you so much. Thank you to all four of our panelists. It's been a pleasure. It's been inspiring to hear you discuss the issues of the moment in your respective field and how you come together to advocate for women. Thank you to our audience for attending the panel. I look forward to continuing the conversation and the collaboration.
I can't hear you.
Oh.
Yeah, hi everyone. Just wanted to also wrap up the session by putting us a couple slides up. So at WMHC 2021, there's a lot of different ways that you can win prizes. You can donate to WMHC and tag us in a post, and you'll be entered to win prizes that are worth actually like up to a few $100s. And then you can also engage in our community. And also if you attend main events, including this event, you can also win some digital gifts. And for this event, the in-kind supporter gift is from Endel, which is an app that provides AI-powered soundscapes that helps you focus, relax, and sleep. And you can get a free 3-month subscription using the code WMHC. Thank you so much.